So welcome everyone to this first webinar of 2022 organized by the Science and Education Committee of the Pediatric Critical Care Society UK. This is a bi-monthly webinar series where we organize the webinars on important topics in pediatric critical care, and the Royal College of Pediatrics and Child Health have given us the CPD points for all these webinars as well. So I'm Akashdeep, I'm the chair for the Science and Education Committee of PCCS, and I'll be chairing this webinar with Ajay Desai, who is the co-chair for the committee, and Vishwaroop Argode, who is the trainee rep on the Science and Education Committee. So today's webinar is on one of the most talked about issues in pediatric critical care, septic shock, and the theme is less can be more. So we have got more than 800 registrations for the webinar. I'm sure at least 50–60% of them will definitely join. And to deliver the talks, we have a star-studded faculty. We'll cover the three very important controversies in pediatric septic shock management: fluids, blood pressure targets, and monitoring in septic shock. But before we start the webinar, just a few housekeeping points. So this webinar is open for all PCCS as well as non-PCCS members, but the recorded version will only be available to the PCCS members. Since it's a webinar format, please put all your questions in the chat box and we'll take the questions for the first talk at the end of the first talk, but for the remaining second and third talks at the end of the webinar. And we will be pasting the QR code for the feedback for this webinar in the chat box. So if you click on it, you will get into the feedback. And once you give the feedback, you will get a CPD certificate from the Royal College. So without further ado, I'm going to introduce our first speaker, who absolutely needs no introduction, Professor Catherine Maitland, who's the chief investigator we all know from the very famous FEAST trial. Dr. Maitland is the professor of tropical infectious disease at the Faculty of Medicine and director of the ICCA-RE Center at the Institute of Global Health Innovation, Imperial College London. And Professor Maitland will be addressing the always talked about controversy in pediatric septic shock on fluids: less, more, or cautious. Over to you, Catherine.
Right, having rehearsed me smoothly transitioning into sharing my screen, I've lost the screen that I'm meant to be sharing. There we are. Has everybody got this screen?
Yes, we have.
Okay, thank you very much indeed. Thank you for a lovely introduction. I'll go into full slide mode. And yes, it's I'm joining you from the coast of Kenya, where I've been for the last 21 years. And this type of research that I've done, I couldn't possibly have done without being based on the continent. So in case anybody was in any doubt of what I was going to talk about, I often say I accidentally did this trial, but it wasn't an accident. It took me 8 years to get funding for it, but the results were not what we were expecting. And it took the world by surprise. And the people who took the most surprise was the investigators, because all the way along we absolutely thought we were doing the right thing. So why was the FEAST trial necessary? At the time when we proposed the study, which is we got the funding for the trial in 2008 or 2009, and this probably the first sentence or the first point is still pretty relevant to today, that children who are hospitalized with critical illness, most will die within the first 24 hours. So the decisions that you make at the doorstep or at that point when the child comes through the door, the golden hour is all talked about, is really important. We had got very, very good solid evidence that pediatric definitions of shock were present in at least 15% of these hospital deaths. So however, the case fatality with shock was around between 15 and 30%. At that point, when we were looking at this, most pediatricians were not giving fluid boluses. We wanted to know whether fluid boluses could improve outcome. Like APLS or what is taught elsewhere, we had our local version, or our version being rolled out in resource-poor hospitals where you get as far as intubation. Beyond that, there isn't any access. But all this sort of basic tenements about ABC were all in what's called emergency triage and treatment. And that was about to be rolled out. And obviously a very central part of that was fluid resuscitation. But doctors were quite concerned. They had been told that their poor little undernourished, quite often undernourished children might not respond in the same way as children elsewhere. They were very concerned about giving fluid bolus therapy. So this is the balance of equipoise, where you've got strong recommendations for a particular intervention, but obviously there's concern on the ground. So the only way to actually work out what to do is to do a control trial. And it took a long time to convince funders to do this, because there was very, very strong opinion, very, very polarized opinion on both sides, with many pediatricians saying this is completely unethical, we know fluids work, whereas you had another camp saying, why you cannot do this trial in the absence of ICU. So that really was the background. While we were trying to generate evidence to say that actually we have given fluids, we've demonstrated that children, this is particularly in children with malaria, because that was the group that was of concern, that they do have signs of shock. This results in low CVP. Their inferior vena cava collapsibility was quite high, but after fluid boluses, we showed that heart rate went down, the IVC improved, collapsibility improved, and also the CVP improved. But also it went into ranges where there was no concern about being fluid overloaded. So these were very reassuring data that we were generating, trying to make us the support for a trial. We included albumin in the trial because we had looked at in phase 2 trials, we compared gelafusing to albumin, saline to a number of other resuscitation fluids. And if you look at the bottom diamond, you see that what comes out in a huge favour is the fact that albumin is better than anything else. So albumin is not available for resuscitation here, but we felt that we needed to include this in the trial because there was a chance that this may substantially improve outcome. Remember, all of these trials have no control arm. These were one fluid versus another in the phase 2 trial. So we get to the FEAST trial. It was a 3-arm trial in children, in a large group of children who displayed, we spent a long time looking at the definition of shock, and then when you look worldwide about the definition of shock, it changes all around the world, and it's sometimes not very well described or the basis, but we definitely put the FEAST trial definition of our shock right in the middle, where we would cover all bases. The only children that we excluded were those with severe hypotension, and that was really only a group of 65. They all received fluid resuscitation. They had a very, very poor outcome. So what I'm going to talk about is the control trial, where we compared albumin, saline, and no immediate fluid boluses. In other words, just maintenance only. Children with in the maintenance only arm, they were all monitored, but those in the maintenance only were permitted to have fluid boluses if they developed hypotension. So that was the design of the trial. It was a very simple design and a very robust endpoint. You couldn't argue with 48-hour mortality. There's no biases with that. And also then other secondary outcomes, 28-day mortality, and a series of safety outcomes, including fluid overload and development of severe hypotension. So we'd been running the trial for approximately 2 years. We were on fire. We'd actually had 4 interim analyses that just said, you're doing a great trial, carry on. And we thought, crikey. We thought we'd get to the point where the Data Monitoring Committee, or the DMC, would say, actually, let's drop it. We were permitted to drop an arm if there was found to be one inferior, but that just didn't happen. So after the 4th interim analysis, we actually increased the fluid bolus volume. So most children only received 20 mils per kilo, and in the final 6 months we increased that to 40 mils per kilo, more in line with what would probably be happening in the emergency rooms in elsewhere, because I think some of the investigators felt what we were giving was almost homeopathic. So that was increased, and then we had a 5th interim analysis. This was over 10 years ago. It feels like it was only yesterday, me hearing this information, because I was in shock when I heard this. I couldn't understand what they were saying to me when the chairman of the data monitoring committee had phoned me back after their meeting and told me this line. And he was very, very careful of what he said. Fluid boluses cannot be of any benefit, or can be of no benefit, and they recommended that the trial steering committee should stop further randomization and the trial to stop. As investigators, we can't stop the trial. We have to have external people to do that. This was confusing to me, but this, for a statistician, the trial wasn't stopped for a 301 value. The strong view was that to continue to show harm to a very, very highly statistical, rigorous value was unethical. And that's what they spent a long time debating. But this is what the results were, and we couldn't argue with them. This is the primary endpoint, 48-hour mortality. Boluses, as you see, we use two different types of fluid boluses, albumin and saline, and their lines are pretty similar, although they have purportedly very, very different qualities. That actually mortality was identical in both of them. We combined them as a result of that. And then you have the no immediate bolus arm, and that was significantly different. We also had a secondary endpoint to day 28, so maybe the kids that didn't receive fluid boluses might all have fallen apart just after the 48 hours, but that result held up to day 28, so this is a very, very robust result. The trial statistician, who's a very eminent statistician from the clinical trials unit in UCL, he was the first one to report a benefit of combination therapy in HIV, so he's had a long experience, said the FEAST trial results were so robust, he couldn't believe it. And the robustness was the fact that when we looked at all of our pre-specified, these are not sort of post hoc analysis, these were pre-specified endpoints, that the actual direction of harm was almost identical in every single subgroup. And sometimes in trials you have subgroups that, you know, if things go one way and the other, but on the balance, when you actually look at it overall, that's the result is what the result is. But what we found is that in every single pre-specified subgroup, there was no evidence that fluid boluses were of any benefit. This is what's called a forest plot. If the diamonds are to what will be the right as we're looking to the screen, boluses increase risk, and you see where all the diamonds are identical. We also, there was a lot of discussion around how we defined our definition of fluid of shock, and we then published another paper showing that actually, you know, whichever definition you use, it doesn't matter. Fluid boluses are harmful, particularly for the quite sort of stringent WHO one. For the WHO one, 48% mortality versus 20% in the control. And overall, that's all statistically significant. I have many questions, but yeah, no, this was done in a malarious area. Maybe it's all being driven by malaria. So we looked at, as we said, we looked at every different subgroup, and these are children with either Goldstein. I suppose there's something that sort of superseded that, but they were all malaria negative. They had either a clinical definition or those who actually had blood culture positivity, and you see it's entirely consistent with the original result. Those who had fluid boluses had a worse outcome. Hemoglobin. A lot of the children had low hemoglobins. Did that make a big difference? You know, even those with what we would call relatively normal hemoglobins. Remember, I said about the diamonds, any diamond to the right-hand side means fluid boluses are harmful. So even in children who didn't have anemia, they all had a poor outcome. And so that certainly didn't explain why fluid boluses were harmful. This paper that hasn't, it was a shame that we didn't get it in a sort of higher, more visible impact, but we had very, very robust data of supporting what the mechanisms of harm were. So we monitored children very, very carefully, as I'd said, and the doctors reported what they thought was the primary endpoint, what actually happened at the end. We had an external endpoint review committee who reviewed all of those endpoints, that largely deaths rather than readmissions or anything, and they adjudicated them. They were blind to knowing what what randomization they were in. So they looked at what was the final end event, and many of those children died in cardiovascular collapse. That was very clear, and that even the endpoint committee throughout the trial were thinking maybe these kids should have had a bolus a bit earlier, but actually that was not the case. So just before we get to that, fluid boluses did reverse shock better than no shock, but this is obviously, these are things that we aim to. Yeah, we've done the right thing. They all had shock to begin with, but particularly fluid bolus, reversed the shock much better than those who didn't have any, but they did not translate to benefit. And as we see here, there was no benefit from that early shock reversal. So that's one of the tenements of the the golden hour, sort of correcting sort of abnormal signs. It improves outcome, but they didn't. So this is the cause of the excess mortality, cardiogenic shock. Children literally died. They recuperated originally, they reversed their shock and then went into catastrophic cardiogenic shock, which is, it wasn't fluid overload, it was basically collapse, where they were found pulseless, and that you can see that how relatively quick that happened after the fluid bolus. Fluid bolus has been given 20 mils per kilo over 1 hour. So when we looked at other predefined neurological endpoints and also respiratory endpoints, there was no statistical difference in those. The primary driver was cardiovascular events. Another paper that we published based on how long were the mortality risks over time. And remember, going back to one of our investigators saying what we were giving were homeopathic. Well, actually, most children received 20 mils per kilo over 1 hour. It was only in the latter part we'll be giving 40 mils per kilo, but all the way through to 96 hours, you had that excess mortality. So showing that it was a very, very strong effect and it lasted for a long time. And it just reminds, we had a cavalier view of fluids, and I think there is an increasing recognition that fluids are a drug. And as I've more recently sort of published on, oxygen's a drug. It has benefits, but it also can have harms. And I think this was, I think the world was ready for a tipping point, because I think people were beginning to increasingly be concerned about excess volume. So after this was published, I presented this for the first time in the ANZICS group. They're the Australian New Zealand critical care group. I'd been invited there just to talk about FEAST. And I phoned Simon Finthorpe and said, Simon, we've got a result. He said, crikey, oh, yeah. And I presented it to them, and Belemo, who's actually written this review about fluid resuscitation, sorry, this might sound a bit like a bit of boasting, but he led a standing ovation, and then he collapsed on his knees when he saw the results. And he for a long time had been wanting to write this, and that almost gave him an excuse. And what he actually shows is well worth for younger people to actually look at this. There was, I think a lot of people thought there was a lot of evidence that went behind fluid resuscitation. There's evidence from animal models, etc., and it just shows the paucity of evidence that there was before. This became a fairly central theme to most sort of resuscitation guidelines. So I'm moving, where has the field moved since the FEAST trial? Obviously, we took a bit of a battering after that from certain groups that trying to find reasons why to undermine the results. But I think that the world has moved on, and this has been caused by quite a number of publications that's showing that actually those patients that had received more fluids, that had a positive fluid balance, had a higher mortality. Well, you could say, well, these are a little bit flawed. Maybe they were the sickest patients and they were more likely to die. But there is a general theme in the publications that there was a concern about, particularly in the adult world, that we were giving too much fluid. Quite an interesting result came out of this, another African trial. This was published a few years ago in 22 patients in Zambian adults. Okay, that they're absolutely not the group of patients that you would normally see on ICUs, but they had early protocolized shock management that considered such fairly similar shock management as you would be giving elsewhere, compared to their usual standard of care, where doctors just were relatively cautious. And so they definitely got a separation in the two arms, more fluid being given in the fluid protocol arm compared to the control. And they once again found almost the same increased risk of mortality in the protocol group and the control that we found in the FEAST trial. And once again, they had to turn to vasopressors in the protocol, but this obviously didn't improve mortality. I mean, the mortality is phenomenal, but I think that's we don't see that in pediatrics. But again, it's a result that's is also consistent with the FEAST trial result. A group of people who you'll all know did a small, relatively small study. It was based at Great Ormond Street and also in the critical care unit in St Mary's, looking at whether after the initial fluid bolus that they could be much more restrictive compared to the standard volume. The trial provided interesting results, no great big huge answers, but one of the things that they did find, and certainly when they interviewed the doctors who were involved in it, the doctors were unhappy to follow standard of care. They were becoming more and more cautious about how much fluid they were giving. And so the standard of care arm, they were not giving as much fluid. So they were the separation between the arms I talked about before was just not there. So I was asked to write an editorial for this. Yes, so other groups have begun to start looking at whether we can be much more restrictive in the fluid resuscitation. Most of the studies that I will talk about, some are studies that are in a relatively small group, but they're just looking at feasibility. Will doctors follow what the restrictive volumes for fluid resuscitation? And the classic trial absolutely and utterly demonstrated it. Again, there was some problems in the standard of care arm. There was less people following what they were meant to do, but they showed that this was safe, and they demonstrated that there was a need to do a much larger trial. Again, this is I'm running through trials that I'm not familiar with, but this is another trial. I don't think that's published yet. I've highlighted a couple of trials that have been published, and there's a couple that we're expecting to do. But really, we're expecting to see the results. Yes, this one has been published and showed fairly similar. People were able to adhere to the protocol, and also demonstrated it was feasible to do this type of study. And the conclusion is that we need to do this in a larger trial. And as I say, just the number of trials that are already being published, their study protocols are being published. These are 2 protocols for adult trials. They're underway, and many are beginning to start to use inotropes a lot earlier instead of using aggressive fluid resuscitation. As what was happening is happening in the Clovis trial. Again, this is not published. This is, I think, raised some concerns in terms of, I think people are trying to beat it up, saying it's unethical to not give fluids, but I've been there. But again, this is not published. Pediatric trials that are going, I'm on the data monitor and on the trial steering committee for this. It's by Melissa Parker. She's again not ready to be published yet. Sorry, this is just a list of trials just to show you how the field has moved on in the last maybe 5 to 10 years that people are beginning to actually look for other ways, more innovative ways of actually managing shock rather than just giving fluids. So in summary, our FEAST trial was the first and only randomized control trial to demonstrate harmful fluid bolus therapy. There is emerging evidence that's pointing to worse outcomes with patients with higher fluid balances. These have definitely generated a lot more trials in terms of being much more conservative. Most have been small but not raised any signal of harm, and lots of trials in the pipeline. The emerging theme is less is probably more. Thank you very much.
Thank you, Catherine. It was a fascinating talk. I'm sure everybody will agree with me. I think we've got to hear from the horse's mouth what Feast kind of told us. So, Catherine, the question always remains. It's always debated. If you go to conference in low middle income countries and people talk about children, they probably behave differently to the volume load than to children in the Western countries. Would you agree with that? And can you predict children who would actually develop volume overload as compared to children who would not?
It's very different. I mean, they may present a lot later and a lot further down their illness than cases in the UK, but the consistency is amazing. So it's quite hard to say that they are different. We've certainly looked at, when we did our physiological studies, they looked like sepsis, they acted like sepsis and they responded like sepsis. We didn't, even we've done transfusion trials, giving a larger volume. Children don't develop volume overload. I think that we have to park that question. In the FEAST trial, we didn't give any diuretics. In our transfusion trial, giving quite a large volume of whole blood, we didn't require to give fluid volume. So we monitored them very, very carefully, and that includes heart rate, respiratory rate, oxygen saturation. We had our eye on these children. So it's difficult to know why they would be very different than children in the UK. You manage African children in the UK. I really hope I'm not saying anything that offends people, but I think there's a diversity, and so you can't say it's genetics or yes, their background, how they live. So the mechanism was cardiovascular collapse. I was going to include in this talk, but I realized that would just be probably too much. We did what were the next set of questions that we wanted to do around fluid, gastroenteritis, the resuscitation protocol from the WHO, 100 mils per kilo over 3 hours. That's phenomenally aggressive. Most of the water that's being lost is in the intracellular spaces. It's not in the circulation compartment. That's phenomenally aggressive. And we actually showed that children we tried to do a slower rehydration. Most children who were defined as having who were 10% dehydrated didn't have that because we weighed them 7 days later. What we did see is that their cardiac markers went through the roof. ANP was basically almost unrecordably high. So there's something that's happening to these kids' hearts. And I think it would be quite nice whether the comparable studies are done. It's quite difficult because when you have sick children, they get inotrope and things that actually might affect myocardial function. So there is something that's probably happening to the myocardium, whether it's the stretch or something. I mean, the other hypothesis that we have, and we actually wrote it down, is these children came in, they were cold, they had thready pulses. We bolused them and they were warm, they sat up, they got better. This is what all the nurses and doctors said. Of course they got better. Maybe that reversed something that was keeping them alive. And because we didn't have plan B, because the inotropes and all of the others aspects of support that you would normally get if you were critically sick. We were reversing the thing that was keeping them alive, keeping their brain perfused, you know, in the face of critical illness. That's actually shock was protective. So it can go out to debate.
Thank you, Catherine. I think it's a very important question by Simon Adele in the chat, and he's asking the fact that shock was reversed by the bolus, but the patients had no ongoing critical care support. Do you think that was relevant? Possibly,
but we have to work within the environment that's available to us, and I think until we can look at different protocols that could be rolled out, that could be affordable in Africa, we have to stick with the best evidence, which is not to give fluid boluses.
Thank you. Thanks, Catherine.
Yeah. And I think everybody wants to do something. That's the problem. You're treating the doctor and often not treating the patient.
I think one practical question someone has asked here is, why have the results of all these studies not translated into practice, i.e. APLS protocol, which still recommends fluids?
I think they have to do studies elsewhere. For more global, worldwide. I mean, we'd love to do Feast 2 somewhere else. I don't know whether I've got the energy to do that, or whether another group should be doing it. Because if you don't believe our result, you know, I think if somebody else did another trial, then that would be wonderful. And maybe that might challenge our result. But I think our result is, yes, it is. It's a very, very large trial. You could say it's just one, but it was multi-centered. It was a phase 3 and very, very consistent with the results.
Catherine, we have a question. It's the last question I'm going to ask because we need to move to the next talk, and the remaining questions I'm sure Prof will be able to answer in the chat. It's a question from our colleague from Brazil, and he's asking, how has the Feast trial changed the local practice? What have you been doing differently? How that changed the outcome, and if it involved starting cardiovascular agents earlier? It's Claudio asking you.
Okay, well, I can answer the first question first, because no, we haven't worked out how to do that in pediatrics. That's not happening. I think we have tried to work with, so the Royal College of Paediatricians have been tasked by WHO to roll out ETAT, and now ETAT has much more conservative use of fluids, which we battled with for quite a number of times, but that WHO haven't changed their guidelines. But through the ETAT course, that's much more conservative, and we hope that people are following that. But it's very, very difficult. It makes a doctor feel so much better when you put a line in and run a load of fluid. You think you've done the right thing.
Thank you. Catherine, in the interest of time, I think we'll have to move to the next speaker. And thank you so very much for being with us. And I think we need to bring you back to answer this 20 million questions which are coming in the chat box. So if you have the time, would you mind
I will answer. I'll try while the next talk, the person's talking to, sorry, I'll try and answer one or two of them. Thank you.
Perfect. I'm going to hand you over to my colleague, Ajay Desai, who's going to introduce the next speaker. Ajay.
Thank you, Akash. Thank you, Catherine. What a wonderful session. Lots of learning. I would like to move on to the next talk by David Inwald, who again needs no introduction. He's an excellent colleague of our PICU family, and he is currently working as a PICU consultant in Addenbrooke's. David Inwald is going to talk about blood pressure targets in pediatric septic shock, permissive versus liberal. Over to you, David. Thank you.
Thank you very much, Ajay, and thank you, Akash, and thanks everybody for the invitation to talk. I'm just going to share my slides, just make sure this works okay.
Yeah, we can see.
Fantastic. Okay. So yes, thank you very much for the invitation. I'm just going to talk a bit about blood pressure targets in pediatric septic shock, particularly in relation to the pressure trial, which I'm going to talk about later on in the talk, which has just started recruitment. That trial has been conducted by ICNARC Clinical Trials Unit. I'm sure lots of people have heard of it. Supports us with lots of pediatric and adult critical care trials, and funded by the NIHR. So just, I'm sure I don't need to tell this audience, but just to remind myself maybe and everybody else what we're talking about here. We're talking about septic shock. So we're still on the Goldstein definitions of sepsis in pediatrics, which were published in 2005. So septic shock means severe sepsis plus hypotension, which means systemic inflammatory response syndrome, which is the definitions there, plus infection plus hypotension. So essentially that is our definition of septic shock. And that's what we're talking about. But in children, there's a number of different pathophysiological processes going on that are important to think about. One is increased capillary permeability, which leads to relative hypovolemia, which is why we give children fluids still. Despite the feast trial, we still do it. There's dysregulation of vascular tone, and some children, as we know, are profoundly vasodilated with warm peripheries and bounding pulses, and some are profoundly vasoconstricted and very, very cool peripherally. And there's depression of myocardial function, which occurs as a consequence of cytokine release, acidosis, electrolyte disturbance, and so on. Now, in any individual child, we don't know which of these is dominating, and we don't know in which proportion they are. So we have to really treat the child blind at the bedside, which is not an ideal scenario because we don't have the tools to investigate these changes in a robust way. Well, I'm sure Shane may tell us a bit more about that in his talk. So really at the bedside, we're in the emergency department and really in most critical care units, we're faced with three questions. How much do we fill? How much do we squeeze? In other words, how much do we give in the way of pressors to cause vasoconstriction, push up the blood pressure? And how much do we thrash? In other words, how much do we give in the way of inotropes to support myocardial function? And we're, you know, we're not blessed with, as I say, robust scientific tools to help us answer these questions. So we have to use fairly basic parameters to help us direct therapy. And again, I'm sure most people in the audience don't need to have any reminder of this, but it's useful to just think about what we're trying to achieve here. What is shock? It's our clinical syndrome of inadequate tissue perfusion. So in other words, delivery of oxygen to the tissues, DO2, is less than VO2, which is oxygen uptake in the tissues. Now, in order to deliver oxygen to the tissues, it's important to remember some basic physiology. Darcy's law is the fluid mechanic equivalent of Ohm's law, V equals IR, which tells us that flow in a system or flow across down in a tube requires a pressure gradient across the tube, delta P, and we need to think about the resistance in the tube as well. So the flow is equal to the change in pressure over the tube divided by the resistance. So we clearly need a driving pressure to maintain blood flow in order to deliver oxygen to the tissues. That is really important. If there's no blood pressure, there will be no flow and no oxygen delivery. There'll be tissue hyperperfusion, organ dysfunction, and potentially death. So extreme hypotension is a bad thing. And that's just showing you the pressure difference there. And the circulation in health is a constant pressure variable flow system. In other words, the blood pressure is the principal variable that we control all the time when we're running or we're sleeping or we're doing whatever we do in the daytime. We regulate flow to individual tissues by controlling local arteriolar resistance, and there's a number of regulatory mechanisms for that. But clearly this is all completely dysregulated in sepsis, in septic shock, and we don't know where an individual patient stands in relation to this and where individual tissue beds stand in relation to this. So thinking about clinical management of patients, we've known for some time there's a U-shaped relationship between blood pressure and mortality in pediatric intensive care. So that relationship was demonstrated by Frank Shan, published in 1997 when the first iteration of the PIM score came out. This is some more recent data from 4 ICUs, pediatric ICUs in London, Great Ormond Street, St Mary's, Brompton, Great Ormond Street Cardiac and General ICU, and Brompton Cardiac, showing the blood pressure distribution on the top panels there in the population in the histograms, and the under 2s on the left and the over 2s on the right. You can see my pointer. And in the bottom 2 panels, we can see the systolic blood pressure on the x-axis and the adjusted odds ratio of death on the y-axis. And you can see there's a kind of inflection point there at 86 millimeters of mercury systolic for the under 2s and 98 millimeters of mercury systolic for the over 2s, showing you that these are the blood pressures associated with the lowest risk of death in these age groups. So this is observational data, not trial data, but it kind of drives in the point that Shan was making, that there's a kind of sweet spot, if you like, with blood pressure. Perhaps may be helpful to demonstrate in clinical trials as well as just in observational data. So we've talked about why extreme hypotension might be bad, that's clear. But what might be the costs of a high blood pressure target? Well, Kath's talked very convincingly about the risks of fluid bolus therapy and fluid therapy with salty water, whether that's in saline or albumin in patients in low-income countries. So I won't talk about that too much more, but clearly there are additional risks from resuscitation fluid, and there's plenty of observational data from high-income country settings and intensive care units that fluid overload is not good for patients in the ICU. Vasoactive agents have side effects. Pressors can cause reduced tissue perfusion. Adrenaline, when used as an inotrope, can cause arrhythmias. It can cause extreme tachycardia. Reduces diastolic filling time, can reduce coronary perfusion and cause myocardial ischemia. So adrenaline is not an agent that's without risk. Central lines, particularly in small children, can be associated with thrombosis and with infection, and these are usually required to deliver these drugs. So there are risks and disbenefits of trying to achieve a high blood pressure target in the children under our care. So what do current guidelines suggest that we should be doing? And I'm really focusing on the guidelines here for high-income country settings. I think the FEAST trial was talked about a lot when we considered the trial data on which to use when we were coming up with recommendations in the ESPNIC SCCM hemodynamic committee, and the recommendations are different for low-income countries where intensive care is not available. But in high-income countries where intensive care is available, this is what we say. Resuscitation should be titrated to clinical markers of cardiac output, and these may include heart rate, blood pressure, capillary refill time, level of consciousness, and urine output. So these are parameters that are very easy to look at the bedside. This is what the SCCM Surviving Sepsis campaign recommended in the most recent iteration of the guidelines in 2020. And unfortunately, most of them, we don't have trial data to support specific ranges in relation to heart rate and blood pressure and so on when we're talking about how we titrate treatment. But we've just said, look at the patient, you're at the bedside, try and work out whether the patient's responding to treatment, and these are the kind of parameters that you might be able to use to do that. Shane's going to talk a bit more about more advanced hemodynamic monitoring, so I'm not going to talk about that now. But in relation to blood pressure, what should we target in paediatric intensive care? Well, in relation to this particular parameter particularly, we were unable to issue a recommendation about a blood pressure target because there is no trial data. So this is the kind of fudge we came out with when we printed the guidelines, which is basically aimed somewhere between the 5th and 50th percentile for age in children with septic shock. And we couldn't come out with a specific percentile because there is no trial data, and the trial group identified that randomized controlled trials would be required to define optimal hemodynamic targets in this particular area. What happens in adult medicine? Well, there's quite good data in adult medicine now, and I'm going to talk a bit about it in a moment, to suggest that targeting around the 5th centile map is certainly not of any disbenefit, and maybe of some benefit. So the adult surviving sepsis guidelines now say target a map of 65 millimeters of mercury in patients with sepsis in the ICU, and that is probably around the 5th centile for adults. In paediatrics, we've got a number of different guidelines. The SCCM ESPNIC guidelines that we've just discussed say target the 50th and acknowledge the lack of evidence. European Resuscitation Council recommend a MAP of greater than the 5th centile for age, but obviously looking very carefully at those clinical markers of cardiac output. And the most recent APLS manual recommends a normal systolic blood pressure. So I suppose they mean the 50th centile by that. So really there's a number of different recommendations without any trial data to support them at the moment. So here's the adult data. There are 3 randomized controlled trials, SEPSIS-FAM, which was 776 patients with septic shock. The OVATION study, which was actually a pilot study in North America, 118 patients with vasodilatory shock. And the 65 trial, which was a huge study done in the UK, published in 2020, coordinated by ICNAR, with nearly 2,500 patients in all over the age of 65, randomized to usual care, which in other words, the target was defined by the clinician at the bedside versus the target of 60 to 65 millimeters of mercury MAP. And the headline from these studies, if you look across the board, is that a permissive MAP target was definitely not associated with reduced mortality, as I think people were hoping to demonstrate. There was a tantalizing suggestion in the 65 trial that there may be some benefit with sepsis in the sepsis subgroup with a P of 0.15, but that definitely wasn't the case when looked across the board. So really no convincing data suggesting reduced mortality with a permissive target, but no increased mortality for sure, and no increase in morbidity either. So in the 65 trial, no increase in the requirement for renal replacement therapy, length of stay, ventilation, or 90-day cognitive outcome. And in some of the smaller studies, there was a reduced incidence of SVT, for example, in the lower MAP target group. So tantalizing suggestions of possibly some benefit in some subgroups, but not borne out across the board. What are we doing in pediatrics? Well, in preparation for the pressure trial, we did a survey of members of the Pediatric Intensive Care Society, over 100 respondents, and not surprisingly, the unit practice that we all know about and love is that the duty consultant sets the target on the ward round according to his personal preference. And those are somewhere between the 5th and 50th centile. So no kind of systematic way of doing this at the moment in our practice. So we thought this was a justification for a randomized controlled trial. We thought the optimal blood pressure targets are not known. The risks and benefits of the current targets are not clear. We felt there was equipoise, and we'd seen that there was a requirement to have prospective trials to look at different blood pressure targets in children to guide our practice in an evidence-based way. So that's where the pressure trial came from. We had to have some acronym for this. This is probably a little bit tortured to call it pressure, but it comes from protocolized evaluation of permissive blood pressure targets versus usual care pressure. So there you are. We started recruitment in December. So what are the inclusion criteria? I mean, essentially, it's children accepted for or admitted to pediatric intensive care on mechanical ventilation and who've started inotropes within the last 6 hours. And we expect that to continue for at least another 6 hours. And we can talk about these more maybe in the discussion. I don't think we've got time to talk about these in detail now, given this a 20-minute talk. There are some exclusion criteria, clearly cardiac and neurological, because our cardiac colleagues said that they were concerned about coronary perfusion in some populations, particularly post-cardiac surgery, duct-dependent circulation and so on, and that they would not have equipoise in this group. So we said infants with children with these diagnoses should not be included in the study. And similarly, brain injury, which we've deliberately left undefined here to allow there to be clinician discretion. But really, we're talking about acute or evolving brain injury for whatever cause, whether it's traumatic or prolonged out-of-hospital cardiac arrest, when people might feel that it's important to target a higher MAP than the 5th centile for neuroprotective intensive care. Pulmonary hypertension, malignant hypertension, death perceived as imminent and previously recruited to pressure. So those were our exclusion criteria. The intervention was a 5th centile mean blood pressure in bands, and that was banded for ease of the bedside nurse to deliver treatment, and control is usual care, so clinician defined. Now, what is the fifth centile map? Now, this is actually a slightly more tricky question than you might think, because there are numerous studies describing different map centiles in children, all of them using different methodologies in different populations. The blue line here represents the data from a paper by Hack and Zaritsky that was published in PCCM some time ago, that derived a fifth centile maps from a population in the United States investigated in a thing called the task force, which was looking at in pediatric outpatient setting, measuring blood pressure by auscultation to define hypertension rather than hypotension, and using mathematics, standard deviations and so on. Hack and Zaritsky were able to define a fifth centile map down to an age of 1. Now this, you may say, is not representative of an ICU population, but this is considered to be the gold standard data in general, the task force data. And you can see that the blue line is where the fifth centile map sits according to Hack and Zaritsky. Problems with this data, as I say, doesn't go down below the age of 1. Now, the last year, the European Resuscitation Council produced a table with fifth centiles that was based on some North American data from Toronto, looking in the intensive care units there, in the pediatric intensive care units, from children with invasive arterial blood pressure monitoring. So a treated population, probably a population that would have been given inotropics if they were hypotensive. And the orange line represents the fifth centile of that population. So we had to choose something, and there are a number of other studies that I can't talk about now, but we came up with the green shaded area there that you can see as our targets for the pressure trial, after some discussion, as I'm sure that some of you are aware. And some of the lower targets in the very little babies were adjusted at the beginning of the trial. And these are the targets in tabular form in the permissive arm of the study. The primary outcome measure is a composite outcome of death and days of ventilator support at 30 days, which is a clinical effectiveness outcome. And there's also a cost effectiveness analysis as well. And of course, there's all the usual secondary outcome measures that you'd expect in any critical care trial also being collected. This is a study with individual deferred consent. The first 6 months is going to be run as an internal pilot. We started recruitment in December. There will be traffic light progression criteria. Our power calculation tells us we're going to need about 1,900 patients. We've got, I think we've actually got more than 17 UK PICUs have expressed an interest in joining the study, which is fantastic. Currently, we're still in setup, so not all the centres are recruiting. We're hoping to recruit for around 30 months, and there will be a 12-month follow-up to look at neurodevelopmental and cost effectiveness outcomes. So we'll be reporting in about 5 years' time if everything goes to plan. There are a couple of other studies going on at the moment. I think Kath alluded to one of them. This is the SQUEEZE trial that's running, that's actually just finished completing in North America, in Canada. Melissa Parker's running this study out of Hamilton. And this is really a kind of early treatment study comparing use of vasoactives to fluid boluses. So very much what Kath was talking about. Now, this study has completed recruitment, and we're waiting for the result. But this study is the hemodynamic targets in this study of the standard hemodynamic targets according to current guidelines. There's no permissive arm. And likewise, there's a study going on in Australia that's run by Lurigan and Schlappbach called the RESPOND study, that's similar, looking at use of early use of inotropes in the emergency department in this population. So again, this study is using standard hemodynamic targets. There's no permissive hypotension arm in this. So as far as I know, the pressure trial will answer some questions anyway, that perhaps these other studies won't answer. So I suppose I need to say thank you to all my co-investigators who are listed there on the left, my clinical co-investigators, and Dermot Short, who's our fantastic PPI rep, and all the ICNARC team, to the Paediatric Critical Care Society and to participating units. So I'm going to stop there. Thank you very much.
Thank you, Dr. David Inward. Great talk, and you gave a great insight into the upcoming pressure trial. Moving on to the next speaker is Dr. Shane Tibby. He's a professor in pediatric intensive care at King's College London, and he's a consultant in PICU at Evanila London Children's Hospital and STRS. Dr. Shane has keen interest in hemodynamic monitoring in septic shock, and today he's going to talk to us about monitoring in septic shock, what is currently monitored, and how aggressive one should be. Thank you. Over to you, Shane.
Thanks, Swoop. I seem to have a problem with sharing.
He's pretty, I mean, he contacts Krishna a lot because he's the link.
Can people mute themselves, please?
I seem to have completely lost the ability to share there. Sorry about that.
Shane, you might have to unshare and reshare again. If that's
Yeah,
okay.
the taskbar's gone. Sorry about that.
No worries.
So my taskbar's completely disappeared. I can see everyone.
We can see your presentation, but not in the presentation mode.
Oh, you can see it. Yeah. Okay, good.
Yeah.
So that's good. Okay, how are we doing now? Can you see it all right?
Yes, we can.
Good, thanks. Okay, well, thanks for the invite to speak. It's a real pleasure. Quite a hard task you've given me, Akash, to talk about hemodynamic monitoring in 20 minutes. So it's going to be a real whistle-stop tour, and I'm not going to cover everything in depth that I'd like to. It's probably going to go a little bit longer, so I'd really appreciate if maybe Swaroop or Akash could give me a 5-minute warning so I know how to speed up.
No worries.
Thanks. Okay, so what am I going to try and cover and what won't I cover? So it's, as I said, it's really a whistle-stop tour of bedside applications, and sort of bundled up in that will be a little bit about how to potentially interpret some of the signals and the physiology behind it, and also some of the limitation of the tools. I think it's equally important to stress what I'm not going to cover. So there's no emphasis on what to do with the readings. That's a personal choice. And we're not really going to cover some of the more advanced techniques, some of which are predominantly research-based. So more advanced cardiac output monitoring, microvascular flow measures, and some of the more sort of really interesting stuff that's going on nowadays with things like transcriptomic profiling. So why monitor? What's the point? Well, you can do it for several reasons. You may be able to diagnose abnormalities in hemodynamics. It may help you to decide both when and how to intervene. And the other side of that is it can help you monitor your response to therapy, and also may have a prognostic role. And what I mean by that is it might sort of guide you to select some of the higher risk therapies, or you can use it as a an entry point to clinical trials, etc. And there's another side to that. So if you're monitoring, there are related questions that you're probably going to ask. And I think the key first one is, I think as David's alluded to, is the balance between oxygen delivery or DO2 and VO2 oxygen consumption adequate. I think you'd like to be able to ask the question, is there a microvascular problem? I don't think we actually have the facility to do that at the moment, but I think it doesn't stop us asking the question. And then we can think about the standard therapies and then when to introduce some of the more advanced or second line therapies. But if we're going to do it right, we have to understand the limitations of the monitor. So we must know how to use the monitor correctly. We must base our measurements on sound physiological concepts, and as part of that, also physiological principles. So what do clinicians think is important? This is not really a surprising slide, but I think it's a very relevant one. This was a survey that our colleague Joris Lemsen in the Netherlands undertook almost 10 years ago at an Septic meeting. And the big five was heart rate, blood pressure, lactate, urine output, central venous oxygen saturations. So no real surprise there. And so I'm duty bound to sort of cover those first, I think. So let's start with heart rate. Well, it's a good one because A, it's objective, and B, it's easy to measure. You can't really muck it up. I think the key concept for me is in the setting of sepsis, extreme tachycardia is always a bad thing. And as with any other monitoring modality, trends actually may be quite subtle and not always apparent from your sort of 5 minutes spent at the bedside. Tachycardia may be a sign of decreased stroke volume. That's what you want to sort of unpick from other potential causes. So why is it bad? Well, it's bad for two things from hemodynamics. In sepsis, you lose your ability to contract efficiently. So this is an example of what we call the force frequency relationship. What normally happens when our heart rate speeds up, we contract more vigorously to be able to maintain the same stroke volume in a shorter cycle time. And that's what I'm attempting to show here. So this is an animal model, and you can see as the heart rate increases on the x-axis, the speed of shortening increases in the white ones, the controls, and it decreases in LPS challenged animals. And the same thing happens with diastole. So you don't relax as efficiently. So your diastolic relaxation slows. It starts at a lower rate in sepsis, and it actually gets worse as you increase your heart rate. And there's not a lot of pediatric data out there looking at the relationship between heart rate and stroke volume. So this is indexed surface area. So these are some unpublished data from 100 children, of which they were predominantly cardiac children. But you can see that there is a definite inverse correlation going on there. So before we talk about the next modality, I guess it's worth pausing and thinking about how does heart rate relate to one of the commonest therapies that we give, which is fluid challenge. So let's imagine a scenario where you've given a fluid challenge and your heart rate hasn't changed. You've still got extreme tachycardia. And to me, that means one of three potential things. It could be just that you haven't given enough, at the risk of sounding like a heretic, or it could be that the cardiac function is actually very poor and your heart is full. And that's, classically that's the setting of something like myocarditis or extreme septic dysfunction. But in the last 2 years, we've seen this increasing phenomenon related to COVID or PIMS-TS. Or there could be another cause. So you might have occult hypothermia. I say occult because the commonest measures for measuring temperature may not be accurate. So, under the armpit or rectally. You may have an arrhythmia, or there may be excess chronotropy, both endogenous and exogenous. But the key thing is you can't really work out any of these potential causes unless you have an additional monitoring tool. So that leads us on to the next one, which is central venous pressure. We're all familiar with sort of Guyton's venous return curve, but just to refresh our memories, is that the venous return actually, I'm not sure if you can see my pointer, but the venous return actually increases to the heart as the right atrial pressure decreases, and then it reaches a maximum somewhere in the sort of negative pressure range. And that's a function of several things, but one of the key concepts is the fact that there's a gradient between the right atrium and the sort of more distal pressure, or what we call the mean systemic filling pressure. And the idea of giving fluid is that if you are underfilled, what should happen is if you start at the base here at 2, is that as you give volume, you may increase your mean circulatory filling pressure as you go up, and it won't make any difference to your atrial pressure, but you can see that your venous return curves increase. The problem is if you give too much fluid, you may actually decrease that gradient between circulatory filling pressure and right atrium, and your right atrial pressure will start to go up and your venous return will actually start to fall off. And just as an aside, I was always fascinated, actually not as a med student, because I didn't pay much attention as a med student, but as a junior ICU clinician, as to why you have this plateau. Why can't you actually keep increasing your venous return? And that comes down to this phenomenon of vascular waterfall that was first shown by Sol Permit in 1963, which basically means that as you get increasing negative pressure in the thorax, the large veins feeding into the thorax actually get pinched, so they work sort of like a resistor. The other thing to just remember about central venous pressure is that it's 0 to atmosphere. And actually the driving pressure, which is filling the ventricle, is the transmural pressure. So imagine two settings where you've got a theoretical CVP of 10. In the first instance, when you're breathing spontaneously, your driving pressure is actually 15. Whereas when you put a patient on positive pressure ventilation with the same CVP, your driving pressure is released to 5. So just bear that in mind when we're actually measuring these things. What's the modality of ventilation and how much positive pressure are you giving? it's not just a number. The waveform is also potentially very useful, and particularly if you follow changes in waveform in the same patient. So what I've shown on the right here is just four example waveforms showing different pathologies. The top left one is Cannon waves that you see with AV dissociation. The top right is the fusion of the C and V waves you get with bad tricuspid regurgitation. Bottom left is tricuspid stenosis. But I think the one I'd like to highlight in the setting of sepsis is the loss of Y descent. And that happens when the gradient between the atrium and the ventricle decreases. So that can be with something like a pericardial effusion or severe RV dysfunction or extreme hypovolemia. In fact, I saw a beautiful example of this the week before last, and I'm really kicking myself for not capturing it. It was a septic child who had a CVP of 9. The guys at the bedside thought we were quite well filled. You could only see an A wave, and when we got the CVP up to 13, the waveform changed completely. You can actually see the A and V wave. Okay, blood pressure. So David's talked about the trial looking at blood pressure, just how we think about it at the bedside. Well, it could be a marker of organ perfusion pressure, and there is potentially also a relationship to flow. We often don't measure flow, but we infer it from other variables. The organ perfusion pressure one is difficult because you can measure blood pressure and CVP, but what they don't tell you is what's going on at a smaller level. So we don't know what arteriolar pressure is, and we don't know what venular pressure is. So we don't really know the true transcapillary gradient, but we can make an estimate. The relationship to flow, and what I mean by flow is essentially stroke volume in this case, is the basis of many of the markers that people have used to try and estimate if you'll be fluid responsive or not. I'll come back to that in subsequent slides. And also the question is there any relationship to microvascular flow? This cartoon is really just a quick run through just to give you in a quite a clumsy way, just an example of how stroke volume might influence a blood pressure waveform. So if we look at the normal situation in systole in the top left, when the heart ejects, a proportion of the blood, up to 40%, will be stored in the aorta, and how much is stored as a function of aortic compliance. And then during diastole, you get recoil of the aorta, and it actually flows down into the smaller vessels. It gives you this characteristic waveform. In other sort of pathological settings, again, these are just very stylized and very simple, but if you had a situation where you had a pure increase in SVR, but normal or even increased compliance, you get more storage centrally, so it will decrease your systolic and increase your diastolic. You get the sort of flattened waveform. And conversely, if you've got the situation where your aortic compliance decreases, then this gives you more blood going peripherally with the initial ejection, and you get this characteristic spiky trace. Now that's an idealized setting, but it's really just to say that there is some sort of relationship between vascular dynamics and stroke volume. And again, pediatric data are pretty sparse, but this looks at the relationship between stroke volume index and pulse pressure. So you can see that as your pulse pressure is very low, you're more likely to have a low stroke volume. It increases up to about a plateau here. So narrow pulse pressure, often a worrying sign. And you can use that at the bedside, provided you're adequately volume resuscitated, and it may give you a clue to the relationship between contractility and afterload. So the first patient has an increased pulse pressure and a reasonable systolic. So that's the kind of kid that there may be a role for a vasoconstrictor, whereas the second child has a narrow pulse pressure. Although the mean is better, the pulse pressure is narrow. And this kid might have poor contractility and SVR. So again, you might think about an inotrope and a dilator. There's a range of tools that we can use to measure DO2 and VO2 balance. So central venous sats is the commonest one, which I'll talk about in a minute. Oxygen extraction ratio, so that's a combination of arterial and venous saturations. And then if you inverse that, the inverse of that is the actually oxygen excess factor, or omega. And the reason that you actually flip that over is that mathematically it gives you an approximation of DO2 to VO2, and it's the ratio of the two which is important. Lactate we'll touch upon not only the arteriovenous oxygen difference, but the arteriovenous CO2 difference, and just briefly mention that there are 1 or 2 NIRS measures, near infrared spectroscopy, that you can use. Okay, CVO2. Okay, this cartoon is really just to highlight what's going on at the sort of microvascular level and to think about some of the reasons why we might have desaturation at the venous end, or in fact an increased saturation. So you can see that as blood flows across the cells, the amount of oxygen that's going to be delivered is a function of how much blood's flowing, so ischemia, if a lack of blood flow, how desaturated the blood is, so hypoxemia, and also the oxygen carrying capacity in the form of hemoglobin, so anemia. So all of these things can actually reduce delivery to the cells, producing a decrease in venous return. On the cellular level, you may have competing things going on. So this concept of cytotoxic or cytopathic hypoxia, where the mitochondria don't work, and that will actually push your venous saturations up, or hypermetabolism, which will work the other way. Anything which increases your diffusion balance may actually cause a problem as well. So you have more O2 diffusing out, but not getting into the cells. And so that will decrease your venous saturation. And then you may have things like precapillary shunts, which will push it the other way, or the P50 can be moved to the right or the left, and that can have opposing effects. So there's a lot of things to think about. And just to remember that the relationship between venous saturation and cardiac output is not a linear one. And also the venous saturations vary from organ to organ and also vary in physiological states. So it's not straightforward. But an easy, sort of a simple way to think about it is if your venous saturations are falling and your arterial saturations are constant, then there's three potential causes: too much VO2, too little DO2, or a combination of both. Okay, moving on to lactate. We've known for more than 20 years that lactate clearance is prognostic, or failure to clear lactate is prognostic. These are two studies, an early adult study and a pediatric study from our own unit more than 20 years ago. But the interpretation of lactate in sepsis is not as straightforward. If you go back 30 years, the textbooks say lactate increases when your DO2 is inadequate and you switch on anaerobic metabolism. It's probably more profound than that. It probably reflects failure of redox potential at the cell, which is a marker of is the cell functioning, basically. So a high lactate is always bad, but there are at least three things in sepsis which can confound it. The first is the concept of anaerobic glycolysis. So basically what you're doing is it's on an oxygen debt, but you're breaking down glucose at a faster rate that it can get into the TCA cycle. So you get a backlog of pyruvate, which then equilibrates with lactate. So lactate high, but lactate pyruvate ratio is normal. And this was shown very eloquently in a French study 15 years ago, where they looked at actually dialysate muscles in the right and left legs. And in one of them, they gave a sodium potassium ATPase blocker, and it helped to normalize the lactate. Lactate also confounds your interpretation of hypoglycemia, so it works both ways. So traditionally in adults, high sugars in treatment of sepsis was a bad sign, but when you look at this group, if you've got high sugars and high lactate, it is indeed bad, but if your sugar's high and your lactate's normal, it doesn't seem to have the same effect. So just an aside. Cytopathic hypoxia we've sort of alluded to, and that's basically where the respiratory chain enzymes are not working properly for a whole variety of reasons, and that you can see tissue ATP in non-survivors of sepsis is reduced in the muscles, whereas survivors of sepsis are much more like control patients. And the last thing is you often get a reduced clearance of lactate as well, so not so straightforward. The good news is that a good algorithm will clear lactate without even the need to measure it. So it's helpful to measure it, but you sort of don't have to. I think that's what this study is saying. And this was a study, it's 10 years old now, but I think it's still very relevant. They were looking at two sort of arms of what we called goal-directed therapy. One was trying to clear your lactate, and the other one was trying to normalize your SCVO2. And the short story was both algorithms were equally as effective. But there was an interesting post hoc analysis of this study, and they said, did you meet, despite which arm you were in, did you meet both goals, one goal, or neither goal? And so if you met your lactate clearance goal, no matter what arm you were in, but you'd failed to meet your SVO2 goal, the mortality was actually quite low. But the converse happened if you actually met your SVO2 goal but couldn't clear lactate. Mortality was 41%. And you can see the same thing in an observational study. The worst combination is high lactate and low SVO2s, and clearly the best combination is low lactate, high SVO2s. But lactate seems to be higher on the pecking order than CVO2. So where are we at now with saturations? Well, I think the ARISE, PROMISE and PROCESS trio studies have kind of put the nail in the coffin for goal-directed therapy, not because it's a bad thing, but I think because we resus patients a lot better now than we used to anyway. The evidence for pediatrics is very scant. The first trial, and one of the only ones I'm aware of, was Dr. Oliveira's trial, I think it's dialed in today, which showed that resuscitating to CVO2 seemed to have a survival benefit. There are some questions about that trial, but certainly it stands out as being the first and largest trial to date. And more recently, Sankar's group in India have actually looked at 2 different modalities of CVO2 monitoring. So that's why I put a thumbs up and a thumb down. It didn't really show a clear difference between the 2 modalities. I'm going to speak briefly about arteriovenous CO2 difference because you can measure oxygen difference. So you might think, why measure CO2? The principle is the same. It's the Fick equation. So rather than VO2, you're looking at VCO2, CO2 production. And there is always going to be a difference between the arterial and the venous sides. So why measure it? Well, it might be a better marker of ischemic hypoxia or ischemia, if you like. Normally, the relationship is, or the difference is less than 6 millimeters or about 1 kilopascal. And this is a lovely, elegant animal model where they looked at 2 types of hypoxia: ischemic hypoxia from reduced blood flow and hypoxic hypoxia from progressive hypoxia. And as you decreased your oxygen delivery to the hind limb, no matter what the mechanism, your oxygen extraction ratio increased the same way. So the 2 paralleled each other. But something really interesting happened when you did the same thing looking at CO2 difference. So the ischemic hypoxia showed a CO2 difference which increased as the ischemia got worse, but the hypoxic hypoxia didn't, it just flatlined. So that's part of the basis for why it may be an interesting measure. And it probably does bear some resemblance to what's going on, or relationship rather, at the microvascular level. So these are 3 groups of adults who had their microvascular mechanics measured. So PPV, the higher the value, the better. So percentage of perfused vessels, 100% being normal. And as your difference increases, your PPV goes off. So there probably is a microvascular correlate. There isn't much pediatric data. My ability to read Mandarin, I was going to say is bad, but it's worse than bad. It's non-existent. But it seems that when your CO2 differences increased, your lactate increases as well. And this isn't necessarily reflected by CVO2 saturations or mean arterial pressures, which is quite an interesting finding. People have then taken the leap and combined the 2 measures, so CO2 difference over O2 difference, and they thought that maybe that's more informative. And the reason for that is that as you get onto the sort of dependent area of the DO2 VO2 relationship, so as your DO2 starts to drop, it limits VO2. When that happens, your RQ, your respiratory quotient, increases, and so that happens in settings of extreme ischemia. And interestingly, when you look at volume responders versus non-responders, patients who responded but didn't actually have an increase in their VO2 tended to have normal lactates. Those that did have an increase in VO2 actually had a lactate debt, and that wasn't reflected in SCVO2 differences. You can get really fancy and you can adjust this because CO2 is not just dissolved, it's also bound to hemoglobin molecules, and that's a function of the saturation of the hemoglobin molecule and the metabolic part of the acid base. That's just fine print. And the studies show that it's a very similar looking graph to what we did with lactate and CVO2, not that much different. Okay. I'm probably way over time.
5 minutes for you, please.
5 minutes? Okay. So what is fluid responsiveness? We give fluid. Okay. So typically the definition of fluid responsiveness is an increase in stroke volume of more than 10%, or some say 15, after a 10 per kilo fluid challenge. And the variability is induced by cyclic changes of positive pressure ventilation. And we use that variability in stroke volume to actually look at our predictive measures, often based on pressures. So this is the same thing illustrated graphically. As you change your positive pressure with positive pressure ventilation, you induce changes in the stroke volume as a consequence of changes in end diastolic volume. Now, there's lots of caveats with that. There's lots of ways to measure it. I've highlighted in yellow because I think these are probably the best markers: SVC or IVC collapsibility, change in velocity time integral, and change in peak velocity peak velocity, peak wave velocity as well. This is just an example of some of the sort of systolic measures that you get. Now, the problem with all these is there's a huge amount of caveats to actually measure these accurately. It's all about the mode of ventilation, that you're in sinus, that you're not spontaneously breathing. And what that means is when you look at the studies where these things are measured under ideal circumstances, you've got an area under the curve which looks great for all these things. But when you translate that into the bedside, into real practice, what happens is if you're ventilating patients at sort of more higher normal tidal volumes, smaller tidal volumes, and you're actually taking into account of all the other things that go on the bedside, your area under curve decreases to 0.5, so not much better than chance. So with that in mind, what do the adults use? And this was the FINIS study, which was a large multinational study of adult hemodynamic practice. And the commonest variable that people used to give fluid was actually hypotension. So the adults are not much different from us. And then the second commonest at 18% was oliguria. The others are all a smattering. And then what did they use to predict whether you'd respond? Well, almost half had no variable, and the commonest variable that was used was CVP, followed by passive leg raising. So with all of these tools, which have been around for about 20 years, people aren't really using them. And interestingly, in pediatrics, the measures that seem the best are very much like the adults. So they tend to be Doppler-based ones. So this is what I was talking about, change in peak velocity and change in VTI. So why is pediatrics worse than adults? Well, lots of reasons. Technically, it's quite difficult to validate these measures. If you think about a stroke volume increase of 10% in a neonate, that could be as small as 0.5 ml. Kids generally have greater tidal volume variability in their ventilation, particularly if you're tiny. And we tend to use pressure controlled ventilation more. And also our vascular dynamics are different. And the importance of that is many of these continuous output measures are actually extrapolating vascular dynamics to stroke volume. So my own personal choice is either an echo-based or a POCUS-based measure, so VTI, PVV, but that requires user expertise. And if you look at the consensus document from Septic, again, they are quite pro-POCUS, strong agreement, but the quality of evidence is almost as low as it gets. So it seems like a good idea, we just haven't tested it. And again, if you look how POCUS has been used in intensive care units, this was a year study in one unit, only about a third of the time they used POCUS, it was to do with hemodynamic evaluation. This is a study I'd actually recommend if people are interested looking at it in the journal. So it's PED-CCM from this year, looking at echo parameters. And the best markers of poor outcome, i.e. mortality, seem to be those that are tissue Doppler derived again. So the traditional measures are not great. Again, it's very difficult to know what to do those at the bedside, but they also tend to be more around diastolic than systolic dysfunction. Now, here's a sort of philosophical point. Let's think about two patients who have got different contractility, okay, but on the same part of the Starling curve. This patient, more normal, will have more variation in their stroke volume. So that patient is predicted to be a responder, the other one isn't. Does this mean that the patient with the flatter Starling curve needs volume less than the other one? Well, I'll leave that for you to think about. But what it does mean is that you're less likely to predict that patient. And also, if you're going to increase their stroke volume, you probably need to give them more fluid because they're on a flatter part of the curve. And this is a derivation of that from my colleague Rohit Saxena, who measured it with me in 100 critically ill children. And we looked at after fluid, the change in end diastolic volume versus the change in stroke volume. And we looked at centiles of contractility based on DPTT. And this gray line represents the sort of magic 15% increase in stroke volume. So a kid on the 50th centile of contractility needs to increase their TDVI by 25, whereas a child with good, excellent contractility is less than half that, and a child with poor contractility is almost double. So it's not a one-size-fits-all phenomenon. Okay, just briefly, skin perfusion and capillary refill and NERS. Capillary refill is measured, but it means different things to different people, which is a function of perhaps seniority and also the discipline you come from. This is an interesting study from I can't remember which centre it came from, but they looked at the relationship between capillary refill and central venous SATs, and it had negative predictive value, which basically meant if your CRT was less than 2 seconds, then you were likely to have a normal central venous SATs, but you couldn't turn that around and say if it was prolonged, it was going to be increased. This is more detailed hemodynamic data, again, from more than almost 25 years ago now from our own unit. And the strongest correlations with capillary refill was stroke volume and lactate as well. So there is a relationship, but it's a function of other variables as well, such as hemoglobin can affect it. This is an interesting study, the Andromeda shock study, which only came out 2 years ago. And it looked at goal-directed resuscitation according to lactate versus capillary refill. And interestingly, the two were certainly very close. And if anything, there was a suggestion that peripheral perfusion-guided resuscitation may have been a little bit better. Okay, I'm just going to say something very briefly about NERS. I'm just going to skip over that, skip over what NERS is. And just say this, okay, if you're going to use near-infrared spectroscopy, you need to know your monitor. They are very different monitors in terms of their outputs and their variability. This is an example of bypass from a child with a monitor, 2 different brands, and you can see that they're very different saturations. And this is some evidence from neonates, which shows that the common monitors can have up to a 12% difference in their average readings. The thing is, there's no pediatric studies, and the adult studies tend to be related to perioperative use. And the take-home message is you may be able to influence things in the OR, which is generally on bypass, but changing things in the ICU is the evidence isn't there yet. But what I would say, skipping through, sorry, not slide skip through, is that the studies are now starting to come out looking at NERS, and there's some suggestion that you might get some loss of cerebral autoregulation and sepsis. This is a very small study, 6 patients, but it shows that those that had a GCSS, which was preserved, had no correlation between changes in NERS and changes in blood pressure, which is what you'd expect, whereas there was a positive correlation in those who had decreased levels of consciousness. It's a minefield because we don't know what changes in CO2 does to that as well. Some information is starting to come out from the pediatric population, particularly looking at NERS on the somatic, so on the flank. And the interesting thing from the cardiac ICU is that the more you use it, the less you end up doing to the patients from the single ventricle population. Trauma, there is potentially some predictive value, is if you have desaturation in your flank NERS, then your odds of having a significant life-saving intervention is about 3 times higher. There is some relation to dehydration, and the more dehydrated you are and the younger you are, the better the prediction. And also in congenital heart disease, this is a suggestion that splanchnic NERS may perform better than renal and cerebral. Okay, I'm not going to really go over this, but just to say people have tried to look at whether there's a relationship with microvascular dysfunction. And this is from occluding a limb and then looking at the recovery slope of the NERS signal. And what it does show is patients in sepsis have a much slower recovery rate, as you'd expect. Okay. Microvascular, we're not going to cover that today, we can't, but I would guide you to this review. It's a very nice review, which was in PED-CCM last year, Matosa. Essentially, this is the seminal study of microvascular dysfunction and sepsis from DeBacker, again, 20 years ago. Patients with sepsis have significant microvascular abnormalities, and a very small study in pediatrics from Anchor Top, 10 years later, showed pretty much the same thing. Okay, unfortunately, our efforts to manipulate the microvasculature have yet to prove to bear any fruit. So the abnormalities are there. It's difficult to know what to do about it. Now, last 3 slides, and then I will stop. Just going to say something about cardiac output monitoring. There's a whole range of different options on the field. They've all got advantages and limitations. We're still not commonly employing them, so I'm an agnostic. I'm neither for nor against. They may provide some ancillary useful parameters in terms of markers of preload contractility, but you really need to know your equipment. Just as an example, if we take one example, so that's unfocused Doppler, so the USCOM. If we look at patients with sepsis from historic studies where the Swan-Ganz was used, we look at patients, what percentage of patients had cardiac outputs in the normal range? Well, in our Pollack study from the early 80s, somewhere between a third and a half. In Mercier's study, 30 to 40%. And then, sorry about this, Akash, but there's two more recent studies. Joe Briley's on the right using USCOM, so really just measuring on children that they came in and looked at the hemodynamic profiles according to the type of sepsis, and also all comers in the intensive care unit. And in this study, 10% of children had normal cardiac outputs and 0% in this study. So to me, that means one of two things. Either the hemodynamic profiles have changed considerably over the years, possible, or the equipment, there is a certain amount of user influence on the equipment. And the last thing to say, arterial hypoxemia is not just a respiratory variable. We think of arterial sats as being respiratory, but they can give us useful information about the cardiovascular status if there are significant cardiopulmonary interactions. So if you look at the standard scenario where you've got mixed venous blood mixing with pulmonary venous blood, which is 100% saturated, there's often a small fraction of venous admixture, about 2% in here of desaturated blood, but you get normal sats. If you have this circumstance where you've got a shunt fraction of, say, 25%, the AV difference is going to be the same, but that shunt fraction in the lungs, which is emptying into here, is going to drag the arterial saturations down. Now, if you then interpret that as a problem with the lungs and ventilate the patient more aggressively, what you may risk is decreasing venous return and also increasing the RV afterload. So you might decrease the RV and hence the LV output. And what happens is you'll decrease your venous sats, and that in turn will bring your arterial sats down further, and it's a cardiovascular reason. And the temptation then is to increase the ventilation even further, and at that stage you may start getting into a situation where you're increasing your shunt fraction, so you get into this vicious cycle. So it's really just to highlight that there is a thing such as cardiovascular interactions. Right, I've gone over time, so I'll apologize for cutting it there, and happy to answer questions. Thanks.
Thank you, Shane. We have time for a couple of questions for each of the speakers. I will start off with a question for David. David, adults give a lot of importance to diastolic blood pressure. You talked about your pressure trial and you were targeting the mean blood pressure. Will you be taking into account your diastolic blood pressure as well?
This is a trial about targeting mean arterial pressure. I mean, I think people do worry about diastolic blood pressure. I don't know, I mean, in general adult practice now in sepsis, the guidelines just recommend a mean blood pressure target, and we're doing the same. So I don't think there's anyone, as far as I know, there's no kind of guideline set targets for diastolic blood pressure. Clearly, if you've got a very, very low diastolic blood pressure, you would worry about that patient clinically. I don't know if that answers the question.
Yeah, there was a question in the chat. I would go on to the next question, David, which is a question from Martin Gray, who's asking that MAP is a calculated value and it tends to vary between medical devices. So depending upon the algorithms used, how would you plan to manage this?
Yeah, no, that's a good question. I mean, I think if you look at, I mean, there is a calculation, obviously, to calculate MAP from systolic and diastolic pressure, and that's fairly easy to do if you've got invasive blood pressure monitoring. Now, the problem is that the portion of time systole compared to diastole changes with tachycardia, as we know. The other problem is that some of the oscillometric devices that are used for non-invasive blood pressure monitoring, they actually most of them use proprietary algorithms to determine the mean arterial pressure, which the companies don't release. So we can't actually do anything about that. I think we just have to accept that this is a pragmatic trial, and we're accepting all forms of blood pressure measurement, and we are not trying to differentiate on the basis of devices. The whole idea of this is meant to be a pragmatic study. So that's what we've done.
Perfect. Thank you, David. Coming to you, Shane, there is a question in the chat, and it is, I can promise it's not from me. It's a question based on liver failure and liver dysfunction. How will the trend of lactate clearance in this group of patients be who present with shock?
Yeah, it's a really good question. I'd hark back to my reference from the French group that looked at lactate clearance. And it's not just the liver, it's probably more complex than that. But yes, logic says that with liver dysfunction, your lactate clearance will be reduced. The problem is there's no easy bedside measure of liver dysfunction in the acute phase. So I don't know the answer to that. Sorry.
No, that's fine. And Shane, the other question, you talked that tachycardia in these patients with sepsis can be a bad prognostic thing. Would you recommend people to start using low dose athmolol if they want to bring the heart rate down to increase the inotropy?
Well, actually, there's a couple of things. There's a couple of questions what that relates to as well. So I see Mohammed Ibrahim said, what is meant by excess chronotropy? That means excessive heart rate, basically, or things that speed the heart rate up. And related, how do you treat excess endogenous chronotropy unresponsive to standard intervention? So I think that's all the same thing, Akash. It's a really good question. We're not commonly use beta blockers because particularly if the patient is already on a beta agonist. So it doesn't make a lot of sense to us to use a beta agonist and a beta blocker together. So if the patient's not on adrenaline and the function doesn't look too bad, you can be brave and use a beta blocker. But I mean, our first port of call is to actually actively cool these patients. And in years gone by, particularly when we used to see a lot more meningococcal disease, one of our thresholds for hemofiltration would not be acid base or urine output, it would be excess chronotropy and temperature. So we would often put these kids on the filter early for that reason. So cooling, because it kills two birds with one stone. It decreases your VO2 as well as decreasing your heart rate. I don't know if that's other people's practice.
Thank you, Shane. And the last question someone had asked is, what is your practice in Evelina regarding monitoring of these patients?
Well, I guess it's fair to say we've gone full circle. We don't do much now. So we've tried lots of these things over the years. And again, I think to me, it's a combination of, I mean, I think our biggest friend is echocardiography and POCUS. So actually seeing the heart, seeing what it's contracting like, getting an idea about filling. We tend not to use the variability measures, just that's because nobody can actually do it. But as more of the younger consultants are becoming more POCUS competent, it may be something that we look at more in the future. And so it's really a combination of an echo and sort of, the usual sort of things, septal venous sats and lactate, just like everyone does, I guess.
Thanks, Shane. David, there's a question for you in the chat box about a subgroup analysis for children with neuromuscular disorders in the pressure trial, and the person is asking that these children do have lower normal blood pressures. So how are you going to target that in your study?
Well, I mean, there's not a predefined subgroup. I mean, I think we could look at them as a post hoc analysis, but I don't think that population is identified as a particular group of interest. So they're not a predefined subgroup. And if I can make one other point, just that I think there's a lot of discussion in the chat about why haven't the feast study findings been translated into guidance? And I did write in the chat, actually, in actual fact, when we wrote the new guidance from the Surviving Sepsis campaign, which I was involved in, we talked a lot about the feast study, and I put a link in the Q&A to the just the kind of brief outline of the algorithm that's currently been promulgated, which actually talks about using much less fluid bolus therapy in low-income countries where PICU is not available. So I think we did do our best to take it into account. But I think the feeling of the group is that although the findings were clearly very robust in that setting, perhaps the key thing is that the trial was done in a setting where intensive care wasn't available, and where intensive care is available, perhaps fluid bolus therapy isn't quite as detrimental as Kath clearly demonstrated in the low-income country setting.
Thank you. I think
Has Akash frozen?
Link which we have posted in the chat box, and give the feedback. After you give the feedback, you will get a certificate of attendance and you'll get the CPD point from the Royal College. So with this, I thank our speakers, Kath, Shane, and David. Thank you so very much. And thank you all of you who spared your lunchtime. We have gone well beyond the time, so thank you for waiting with us. And we'll see you on the March the 20th when we have a webinar on ARDS, and we've got a galaxy of stars again. Thank you. Thank you. Bye-bye.